and welcome. This video is to explain the methodology through which the evidence levels are determined in the green top guidelines. This information is actually available at the end of each guideline. The different components of the guideline include the following. The first section includes the executive summary, which gives the grades of recommendation. This is followed by a small section called purpose and scope of the guideline, followed by background and epidemiology. This is followed by identification and assessment of advice or evidence, followed by clinical issues. In this section, details are given of the grade and the level, as well as detailed information about the clinical issues of diagnosis, assessment, management from medical point of view and surgical. This section is then followed by the outcomes for mother and baby, followed by who should be on the team, the clinical governance, training, feedback, etc. A small section on recommendations for future research. The guideline group go through all the evidence to compile the guidelines, but they also identify areas which are for future research, and this is documented and put down in the guideline. A large number of topics for the concerned guideline is also mentioned for audit purposes. Useful links and support groups are mentioned, followed by disclosures of interest and funding. In the last section, there is supporting information, and this is in the form of appendices as well as references. So basically, the most important aspect for the clinician when they go through the guideline is to go through the executive summary, and which gives the grade of recommendation. And if you want the details about the executive summary or the points mentioned in the executive summary, then we go to the clinical issues, which gives a very detailed account of each recommendation along with the grade for each recommendation and the level of evidence available for each recommendation. So in summary form, we can say that the grades of recommendation are mentioned as capital A, B, C, and lastly, good practice points. These are described on the final page of each guideline, and in addition to the grades of recommendation, there is also a summary of evidence to mention what is the level of evidence that is available for each recommendation. And this is mentioned in a different way in numerical terms. So at the end of each guideline, this table is given, which is called classification of evidence levels, and which can be referred to every time you read the guideline. For the purpose of making it easier to read, I have broken it down into two sections. So the classification of evidence levels is categorized as 1++, 1+, 1 minus, 2++, 2+, 2 minus, 3, and then 4. So 1++ means high quality meta-analysis, systematic reviews, or randomized control trials, or randomized control trials alone with a very low risk of bias. 1+ means well-conducted meta-analysis, systematic reviews of randomized controlled trials with a low risk of bias. So you can see the difference between 1++ and 1+ is that in one there is a very low risk of bias, and in the other one there is a low risk of bias. Then we come to the number 1. In this, the meta-analysis and systematic reviews or randomized controlled trials are with a high risk of bias. So in other words, amongst these three, 1++ is the highest quality of evidence that can be available and that has been approved by the people who have written down the guideline by reviewing the literature and by ascertaining what is the level of evidence and what is the level of bias. We then move on to 2++. These are this recommendation or this level of evidence is made on the basis that there is a high quality systematic review of case control or cohort studies. So here the difference between 2+ and 1++ is that in 1++ there are randomized control trials, whereas in 2++ there are cohort or case control studies, which are of high quality care and with very low risk of confounding, bias or chance, and a high probability that the relationship is causal. 2+ level of evidence means that it is a well-conducted case control or cohort study with a low risk of confounding, bias or chance, and a moderate probability that the relationship is causal. And then 2- is the same, except that there is a high risk of confounding, bias or chance, and significant risk that the relationship is not causal. So you can see that in the three areas of 2, there is 2++, there is 2+, and there is 2-. So in all of these, the kind of studies that have been included are not analytical studies, but rather they are high quality case control studies or cohort studies. And the risk, depending upon the risk of bias or the risk of the confounding factors, they have been then further categorized into 2++, 2+, and 2-. Moving on to the level of evidence of 3, these are non-analytical studies, for example, case reports and case series, just on the basis of standalone case reports and not on the basis of meta-analysis or systematic reviews. And in the 4th level of evidence is when there is an expert opinion. Now, expert opinion does have an important say in the matter of decision making for clinical matters, because expert opinion is usually available when there is no evidence available on the basis of randomized control studies, on the basis of systematic reviews, on the basis of meta-analysis, case control, cohort studies, or any other kind of non-analytical studies. So an expert opinion has 2 important values in terms of clinical opinion making. The first value is that the expert opinions are usually made by academic faculty or academic clinicians who are in the process of reviewing literature, who are in the process of understanding research and of also understanding the latest kind of evidence that is available. And secondly, expert opinions are usually made on the basis of an understanding of the contextual situation in terms of the diagnostic methodologies available, in terms of treatment modalities available, in terms of financial or economic realities of the health systems. So we then move on to the next level of evidence, which is the grades of recommendation. So alongside the levels of recommendation or levels of evidence is the grades of recommendation. Again, this is a table that has been given at the end of each guideline. And for the purpose of understanding a little bit better, I have divided into 2 sections. So as far as the grade of recommendation is concerned, the grades of recommendation are divided into the capital letters of A, B, C, D, and in addition there is a section called, or a subsection called, good practice point, which is then marked on the guideline as a tick mark or as a correct mark in front of the recommendation. So when we say A grade of recommendation, it means that at least one meta-analysis, systematic review, or randomized controlled trial has been included in this recommendation, or is the basis for this recommendation, and this means that the rating is 1++ or 1+. When we say that the grade of recommendation is B, then this means that a body of evidence including studies rated as 2++, directly applicable to the target population and demonstrating overall consistency of the results. When we say that the recommendation is C, it means a body of evidence including studies rated as 2+. When we say that the grade of recommendation is D, capital D, this means that the evidence level of 3 or 4 or extrapolated evidence from studies rated as 2+. So when we use the word extrapolated here, then this is not something that clinicians can do of their own accord, because this is done by researchers who take a hard look at the data and then see if this data can be extrapolated to other situations. So beware that the word extrapolated here is not something which is the decision making on the part of the clinician, but it is the decision making on the part of the consultants or the researchers who make the guidelines. Lastly, there is a section or a subsection called good practice points. So good practice points is a recommendation which is made on the basis of clinical experience of the guideline development group. So different guideline developers will use different terminologies to describe this, but for the Royal College of Obstetrics and Gynecology Green Top Guidelines, good practice points are indicated by a tick sign in a box which is placed in front of the recommendation. So here I'm going to show you an example of the way that these recommendations are made. So here we see a sample of section of Green Top Guideline for 2019. For this has been taken. This excerpt has been taken from the executive summary of the guideline for maternal collapse in pregnancy and puerperium. And this Green Top Guideline number is 56, and this was published in 2019. So as you can see here, there are four recommendations that have been made, and in front of every recommendation there is a small box, and inside the box there is either a tick mark or a correct mark, or there is a letter. So in front of the first one is this little tick mark, which means that this is a good practice point, which is being declared by the guideline group. Here we have C. This recommendation is capital C, and the fourth is a capital D. This is an example of a section from the same guideline as before, but here this excerpt has been taken from the clinical issues, not from the executive summary. The guideline covers the different causes of maternal collapse, the identification of women at increased risk, and the management of maternal collapse. So this guideline is recommending that the modified early warning score system, which was first developed, or the MUSE system, it was introduced on the basis that a deterioration in simple physiological vital signs will precede significant clinical deterioration, and that early intervention will reduce morbidity. They are now extensively used in acute settings, and critical care through the optimal system has yet to be identified. So the reason why it has been shown as evidence level 2++, which means that it is a lower level of evidence, is because the MUSE has not really been validated for pregnant women. And therefore, this quality of evidence is not as high. This table has been taken from the information provided in the document of guidance for guidelines, Appendix 7. So this can be accessed through the internet. If you look for guidance for guidelines, RCOG, you'll find this document, and if you go to Appendix 7, then you will see this table. There is a lot of repetition of information in this table, according to what we have already talked about. And as you can see here, the classification of evidence is documented as 1++, 1+, and 1-. In the next row, there is 2++, 2+, and then 2-. In the third row is 3, which is non-analytical studies. Example, case reports or case series. In the fourth row is expert opinion. So we understand from this table that when the evidence is classified as 1, it is of a higher level, and when the evidence is classified as 3 and 4, it is a lower level of evidence. This means that the higher level of evidence has been taken after rigorous studies in the form of meta-analysis and systematic reviews of randomized controlled studies, and based on the risk of bias in these studies, the evidence has further been classified as ++ or 1+ or 1-. From the clinician's point of view, we must remember two important things. The first is that everything does not have available evidence. However, because we are now practicing in a world where evidence is very important, and especially in a situation where there is litigation, the clinician must be able to satisfy the patient as well as the patient's legal team that whatever decisions were made on the basis of evidence. Therefore, it is very crucial that evidence-based guidelines must be followed by clinicians. The second important aspect that clinicians should remember is that not every clinical decision making has available evidence, and so the clinician must know where evidence is available and where evidence is not available. Where evidence is not available, the clinician should go for expert opinion by guideline developers. And if even that is not available, then there is a backup of institutional recommendation or institutional level of practice plan or practice points. The common guidelines which we use in obstetrics and gynecology are the Royal College guidelines, the American College guidelines, the guidelines which have been produced by the European Society for Human Reproduction and for Endoscopy, and the NICE guidelines. With this, we come to the end of the video. If you like this video, please press the like button. Do subscribe. We really request subscription from our viewers, especially if you are satisfied, to allow us to continue with making these videos. Share the video with friends and colleagues. Your comments are extremely useful for us, and press the bell icon if you wish to be notified for future videos. Thank you and goodbye.